All right. So exam one review for PNR 205. So just as a brief overview, so it's going to cover the information from from week 1, 2, and 3. So it's going to be chapter 4, which is the, how practical nursing evolved. Um, it will also be, sorry, chapter 12. So chapter 4, again, how nursing evolved. Chapter 12 is the nursing process. And then let's see, week 2 I'm sorry, chapter 8, which is effective communication, chapter 9, assertiveness, and then chapter 14 was the interdisciplinary team. And then for week 3, we had chapters 10 and 11, which was spirituality, as well as cultural uniqueness. Sorry, can't say it. So again, it's going to be chapters 4, 12, 8, 9, 14, 10, and 11. So I'm going to share my screen. I have my PowerPoint for you. And so when we look at the nursing process, so we talked pretty a lot about the nursing process, and each individual's role within the nursing process. Can't, there we go. So for the nursing process, who does what? And so assessment is generally done by the RN. The LPN can gather data independently, right? And then we can bring that back to the RN. Diagnosis, the RN will use NANDA to formulate the nursing diagnoses for that patient. And then planning, the RN and LPN, or the RN does the planning process, the LPN will coordinate or collaborate with the RN to develop the goals. And then implementation, the RN and the LPN both carry out orders independently. And then evaluation is done by the RN. The LPN will report any recognized findings to the RN.
So the RN does all 5 independently, but the LPN does the implementation and the assessment independently.
Good job. Yes.
Okay.
Yep. So the LPN functions in an independent role by collecting data and then implementing interventions. The RN creates the nursing diagnoses. The LPN will collaborate with the RN on the plan of care, right, and the evaluation of client outcomes. The biggest, right, safety is the priority nursing intervention for the client. And then before collaborating on the plan of care, the LPN must assess the client's understanding. What do they know about their condition? What are their priorities for change? So again, the RN can do all 5 aspects of the nursing process, whereas the LPN can do the assessment or data collection and implementation, right, independently. Patient teaching. All right. So we know patient teaching is another big part of what we do as nurses. So RN always does the initial teaching and the initial plan of care. All right. So the RN will set up and say, this is what the patient what the patient needs. And then we'll provide that initial teaching. And then the LPN will reinforce the teaching that's already been provided. And then, of course, collaborate with the RN. When we look at this kind of goes back to chapter 4. And so the U.S. Department of Vocational Education performed a comprehensive study that identified agreed upon practical nursing tasks. And so terms were used to describe their scope of practice. And so these terms were judge, recognize, determine, and appraise. We do our assessment, right? We're gathering subjective or an objective information. So remember, subjective information is anything that the patient tells us or the caregiver tells us. It's, we can also say these are symptoms, right? So my pain is a 7 out of 10. I feel nauseous. I'm hungry. I feel sad today. And these are things that are a little bit more difficult to measure, right? Objective information or signs. These are data that we can verify, right? So vital signs, right? We can verify. Skin turgor, skin color, what the wound looks like, height, weight, their level of consciousness, even looking at, some of the test results, whether, x-ray lab, right? That's all objective information. That is stuff that we can measure, that we use our senses to obtain. So subjective are symptoms, objective are signs.
One quick question.
Absolutely.
So just to go back a little, you said the RN does the initial teaching and the LPN does the reinforce.
Mm-hmm.
Okay, and then you said judge, the record, appraise, determine, and what was the last one?
Judge, recognize, determine, and appraise.
And
Those
what are
were,
these?
I'm sorry?
And what are these?
These were developed by the U.S. Department of Vocational Education. Those were the terms that they used to define the practical nursing role. And you can see how it directly correlates, right, to the nursing process. But those were the initial terms for the scope of practice for the LPN.
Got it. Thank you.
Of course. All right, so safety. We know safety is the one of the priority for providing patient care. So how we, the things that we do to provide safe patient care. So if a patient complains of feeling lightheaded, all right, so some of the safety interventions that we could put into place for somebody that is feeling lightheaded would be, fall precautions, making sure that they have their non-skid socks. They're, making sure that we are assisting them with ambulation. We can also do those orthostatic vital signs, right? That will help us determine, is there a drop in their blood pressure, right? When they're changing positions, which increases their risks for falls. Post-op patients, some of the safety issues that we would use for our post-op patients, the pneumatic compression devices or sequential compression devices, right, to help prevent DVTs. You can also do anticoagulants, right, whether it's heparin. There's so many new ones out there, whether it's heparin, whether it's the enoxaparin, which is your Lovenox. And of course, there's warfarin. And then there's, some of the other newer anticoagulants, right, that don't require as much blood work and screening. Pain is another big post-op concern, right? Monitoring their pain, making sure that we are providing for effective pain management. And vital signs, right? Patients that are having respiratory difficulties, right? One of the first things that we can do if we walk into a patient's room, right, and they are short of breath, elevate the head of the bed, sit them up, okay? That's going to help to allow them to take those deeper breaths, right? Get a little bit, relieve some of that shortness of breath. Incentive spirometry, right? I don't know if anybody's ever, if you've used an incentive spirometer, right, you hold on to the thing, and there's a tube that puts in their mouth, and then they breathe in real deep, and the little ball goes up, right, or the little pin goes up, whichever one that they have. But using the incentive spirometers like 10 times an hour, right? I used to tell patients, like, when, if you're watching a TV show, every time a commercial comes on, go ahead and use your incentive spirometer, right? Kind of gives them a time frame. Deep breathing exercise, turn, cough, and deep breathe. That's another important thing. Make sure that we are, adequately ventilating, especially if after they've had surgery and in general anesthesia, right? Helps to get that anesthesia out of their lungs and prevents that atelectasis from occurring. And then oxygen is always an option too, right? We can do oxygen to help any respiratory difficulties. All right, so again, this goes back to teaching. So the LPN will most often reinforce client teaching and notice changes needed to the plan of care during the implementation phase of the nursing process, right? So you're going in and you're doing your implementation or your interventions, not implementations, your interventions. You're, following up and you're reinforcing the education, right? That is when you are going to most likely notice any changes that may need to be made. And then you can go back to the RN, right? Collaborate and develop new interventions, look at those goals. Nursing interventions are patient specific, right? Got somebody else join in. So nursing interventions are patient specific for what the nurse will do to assist the client reaching their goals and identified outcomes, right? So whatever the goals are, short term, long term, those interventions are specific to the patient, all right? And so, yes, there are generalized care plans out there that, are just general interventions that could potentially be but we want to make sure that we customize it, right, to make sure that we're meeting our clients' specific needs. So remember, when we look at our goals, right, goals need to be measurable, they need to be realistic, and they need to be time specific. So measurable and time specific, right? That allows us to determine whether or not a goal has been met, right? So if we want our post-op hip replacement to walk 20 feet by post-op day 1, right? That's measurable and it's time specific, right? It also realistic. 20 feet's not necessarily a long distance, but I wouldn't want to have my post-op hip replacement running a marathon by post-op day 3, right? So we want to make sure that they're realistic and tailored to the needs of that person. All right. So I hate that. It's already up there, but let's show it again. So which care plan will provide the most thorough, comprehensive care for the client? So a individualized, a standardized, or a generalized, or a non-specific. So which one's going to be the most thorough, comprehensive care for our client?
Number number one, because it is tailored to the client.
Absolutely. It's individualized. And like I said, there's standardized care plans, right? You're going to your EMR system. A lot of your EMRs will generate nursing diagnoses based off of the, assessment and the medical diagnoses that are entered into the client's chart. And then when you go into the care plan, based or underneath that nursing diagnosis that is chosen is going to, give you a long list of interventions that you could potentially choose from. And those are just, they're generalized, right? So let's just say if we had oh, I don't know, let's just say I'm going to use risk for falls as an example, okay? So I have a client that's risk for falls, right? There's going to give you a list of 30 different interventions that you could potentially use. All right. And then you're going to individualize those to your client's specific needs. So that's going to give you the most thorough, comprehensive care. We look at client-centered, relationship-centered care, providing care that's respectful of and responsive to individual client preferences, needs, and values, and ensuring that client values guide all clinical decisions. All right, so that's that client-centered, relationship-centered care, right? The client is the center of our nursing process, right? And, they are not try to, they are included in establishing in establishing the plan of care. So we're going to focus on the client's needs, right? What are the client's individualized needs that we need to incorporate into their care? Also want to look at client preferences. And so client preferences could even be things like their food preferences, their spiritual needs, their what else am I trying to say? Their cultural needs, right? We're incorporating everything within that plan of care. And the client is given information for informed decision making. So when we look at that, right, that goes back to the ethical principles of nursing, right? We give our clients all of all of the information necessary, the good, the bad, the ugly, right? So that they have all the
Hello?
information. I'm sorry.
Can you hear me?
Yes.
For some reason, you're going in and out.
I'm sorry. All right. I'll try to sit closer.
I don't,
Um,
I don't think it's you.
oh, I know
Maybe.
you're really soft, but I can hear you. It's just very low. Um,
I wonder if it's my internet connection. Hmm. Okay.
so again, we're going to give the client all the information, right, that is necessary for them to make a informed decision, that is the best decision for them. And then, of course, we make sure that we respect their decisions, right, without any kind of bias. So that brings us to communication, and we've talked a lot about communication since the beginning of the course. We understand how important it is to have, open, therapeutic communication with our clients as well as their families. Um, we do that interview with our clients so that we can obtain all the information we need about them. Um, and, one of the ways that we do that is through asking questions. And so we have the two types of questions. We have open-ended and we have closed-ended questions. Closed-ended questions are not going to give us a whole lot of information. A lot of times this is going to be, right, a yes or a no question. Usually a very specific answer that we're looking for, right? Are you hot? Are you cold? Are you hungry? Or are you thirsty? Trying to think of what else. And then of course your open-ended questions, right? Those are going to elicit a lot more information from our clients. And so this is, your who, what, where, when, why, how questions. Can you describe your pain? What do you know about your wound care? What is your morning routine? If they've had an injury, like what happened, right? So again, closed are very, requires a specific answer. A lot of times it's a yes or a no, or something along those lines. Whereas an opening question, right, we're eliciting a lot more info. We're hoping to elicit a lot more information. Then we have our S bar. S bar is an amazing communication technique that we can use, right, when we're communicating either to providers or even to another member of the healthcare team, like when we're doing our shift report. S is for situation, right? B is for background, A is for assessment, R is for recommendation. So situation, these are things like, if you're calling the provider, like who you are, where you're calling from, who you're calling about, and then what the problem is. When did it start? How bad or how severe is the problem? Your background is going to give a little bit more information about your patient. So what their admitting diagnosis was, when Hey, Corey, I don't know.
Can you hear me?
Are you there?
Yes.
Okay. Yeah, I'm not sure what happened. Zoom just decided to stop Zooming. And so I not sure. So I just decided I joined from my phone, which I don't have um, I don't have the PowerPoint on my phone. But I couldn't get it to, kept giving me an error. Zoom kept giving me an error on the computer. So I was like, well, let me try my phone. And so that seemed to work. Um,
Okay.
but I'll post the PowerPoint. So, but I will keep on going. So, we've talked about the assessment, right? What we think is going on based off of the information from the situation in the background. And then what's the recommendation? And so what do we need from the healthcare provider, right? So do we need them to come see the patient? Do we need an order, right? Do we need to transfer the patient? Or do we need a consult with another provider? Like what is, what do we need to do?
And that's for recommendation.
That is for recommendation. Yep. And then or I'm sorry, yeah, no, yeah, I'm sorry. That is for recommendation. I like lost my train of thought for a second.
So that'll be in regards to the patient, what we need for the patient, but from the physician or
Correct.
lab. Okay.
Yes. Do we need a lab? Do we need do we need them to, depending on where we are, do we need to go to um all right. All right, I fixed the issue. I don't know what happened, but we fixed it. So yes, do we need to go to a different level of care? What do we need to do, right? So think about it. If you're working in a long-term care setting and you have somebody that, is declining, right? Maybe we need to send them to an acute care hospital, right? Or maybe they're in med surge and they need to go to ICU, right? What's going on? So that would be your recommendation, right? Or maybe it's just getting a lab test, right? Or, maybe they need some oxygen, or whatever it is, right? You want to make that recommendation. All right, so I covered that. All right, let me go to our communication and our listening techniques. All right, so we know active listening. We've done, like I said, we've talked a lot about communication since the beginning of the course, because communication is such an important part of what we do. And so the most important part of communication is, therapeutic. It's, building that therapeutic communication to build that therapeutic relationship is that active listening. Um, and so therapeutic communication, that's the interaction with, between the nurse and the client, that focuses on the physical as well as the emotional needs. And those interactions are going to require the use of effective communication strategies, right? Um, and so key factors in active listening is your purpose, your disciplined attention, and your focus, right? So purpose is why are we having this conversation? Your disciplined attention means that you don't assume accuracy of information without checking it out first. And then focus means that all your senses are alert to the cues that the client may be communicating. So we need to look at both the verbal and the nonverbal. Um, and sometimes, and I'm not gonna lie, right? Sometimes people talk a little bit more than others, right? And so you may be having a conversation, but we really need to stay focused. Because sometimes we can sit there and we can hear people talking to us, but we're really not listening to the word, we're not really hearing the words. And I've known sometimes too, like if I have a client or a patient that's just talking and talking and talking and talking, sometimes you tend to zone out a little bit. You got to try to remain focused. So some of the excuse me, some of the active listening techniques that show that you were listening to them. Restating is repeating what the client said in a slightly different way. And so like the client says, my chest hurts, I can't sleep at night. So restating would be, you've been unable to sleep because of your chest pain. So just repeating what the patient said in a different way. Clarifying is asking question in response to a patient's statement to be sure that you understood what they said. So they tell you their chest hurts. Then, you can ask them, well, show me where your chest hurt, or, point to where your chest hurts. Exactly where does your chest hurt, right? That'll give us some clarifying information. Reflecting is putting into words the information you receive from the patient at an effective communication level. So I'm going to use the one from the book here. So the book, the client says, I'm sick of seeking healthcare providers and not getting answers. So a way that we could respond to that using reflecting would be, you are upset with the lack of answers to your health problems, right? So in a way, it's very similar to even clarifying, right? We're putting the words in to make sure that we're understanding what they're saying. Paraphrasing is expressing in our words what we think that the patient means, right? So it's kind of, this is, like when you're doing research for one of your papers, right? You paraphrase your references, right? You're taking that information and you're putting it into your own words, to make sure that we are understanding. Minimally encouraging, these are sounds or words to encourage the patient to continue talking, right? So, go on, tell me more, yes, okay, right? You're just encouraging them to keep talking. Remaining silent, and this, using your pausing. And so, not everybody is comfortable with moments of silence. It can, a lot of us feel the need to fill the void with words. Um, but this allows the clients to tell their story. It also, allows them to gather thoughts, not just them, sometimes for us too, right? If we're thinking about what a client has just told us and we need to process before you respond. Um, Using silence can be an appropriate communication strategy, especially I think of working with older adults, right? Sometimes they need a second to process the question that you've asked or the information that you've given, right? And they just need a minute to kind of gather their thoughts. Summarizing is stating the main data that you've got. And this could be like, okay, gathered all my information. I'm going to just repeat it back to you and say, this is what I heard. Is that correct? Which brings us to validating. So you've summarized the information that you have received from your client. And then, if once I say, is this correct? Right. And that allows them to say, yes, it's correct, or no, this is not correct. This should have been this. And so that allows the client to correct any information that may have been misunderstood or misheard. So what's the difference between clarifying, restating, and paraphrasing? And so we kind of went through this, right? So clarifying is asking a closed-ended question in response to a patient's statement to be sure you understood. So the patient says their chest hurts. The nurse asks, tell me exactly where it hurts. Restating is repeating what the patient said in a slightly different way. So my chest hurts and I can't sleep at night. And so our answer would be, you've been unable to sleep at night because your chest hurts, right? That's restating. And then paraphrasing is putting in your words what you think the patient means. So they say, I don't think I'm being told the truth about my condition. And we can reply, you believe you've not received all the important information about your health condition, right? So they're very similar but different, all right? No, I don't know why. My slide didn't want to move. All right. So positive communication techniques, right? We talked about these. Developing trust through openness, honesty, integrity, and dependability. So remember those I messages. What were I messages?
Is it like putting yourself in the patient's shoes?
It's more of, how do I explain it? It's more of a technique so that we don't make the patient uncomfortable or somebody else uncomfortable. So, um, iMessages, they allow I'm sorry, they allow for to prevent defensiveness. I don't know how I can't speak all of a sudden. Um, so, um, it's kind of taking the reflection, it's reflecting off of them. So like if somebody is upset, if somebody is yelling, if somebody is, or it feels like you're not understanding, you can use an iMessage like, trying to think of a good one. Um, I'm trying to understand, or I may be misunderstanding what you're saying. This is what I heard you say. Am I correct? Or am I incorrect? Right. So we're taking it away so that it's like, um, I don't know, I'm trying to think of something, and all of a sudden my brain just doesn't want to. Um, it's it's just preventing them from becoming defensive. And I'm trying to think of a good one, and all of a sudden I can't. Um,
So, like if the patient is upset, you will say, how can I better understand you? Or how can I help fix the problem?
yeah, yeah. Or, it could be if, yeah. You're not, it's not accusatory, right?
Okay.
And so when we look at it, if somebody were to say, yeah, you're not answering the call light, I don't understand why it's taking so long for you to answer the call light, or something along those lines, right? Um, you know, we can reflect it. I'm working on that. I'm trying to figure out the issue. Or rather than going, did you even push the call light? Like, right. So
Okay.
and I've had that happen, I've had that happen where clients are like, I've been on the light, I've been on the light. And I'm like, okay, I understand that. I'm sorry. Let me figure out what the issue is. And they haven't hit the light because they're pushing the wrong thing. I work with a lot of dementia patients, okay? And I'm like, I
Hmm.
have to explain that pushing the remote control is not pushing the call bell, right?
Gotcha.
Um, but if I went in there and said, well, you didn't push the call light, right? That's gonna automatically put them on the defensive, right? And then they're gonna shut down rather than, okay, I'm here. I will try to figure out what's going on, type of thing, right? And then, I'll do the whole switcheroo, like, let me take the remote and give you the call bell, right? Um, so it's just avoiding, them becoming defensive, right? Um, Establishing eye contact is another one. When we look at establishing eye contact, of course, we want to make sure that we're taking into consideration um any cultural um, you know, um preferences that we may, right, come into play, because some cultures are not big on eye contact, others are. Keeping promises, and this is a big one in healthcare, and this is something that everybody probably needs to work on, is keeping promises. If you tell a client, hey, I'm going to be back in 5 minutes because I have to go do something real quick, go back in 5 minutes. Even in that, even if it's in that 5 minutes, you still don't have the time to do what they need you to do. Be like, look, hey, Mrs. Jones, I told you I'd be back in 5 minutes. The task I was previously doing is taking a little bit longer, but I wanted to come back and let you know, right? Can you give me a little more time and I'll be back in as soon as I can, right? keeping those, because if you just don't come back in 5 minutes and you come back in an hour, right, they're going to be upset. But if they know, hey, you didn't forget about them, you just got caught up with something else, but let them know that they're still a priority to you, right? That's super important. Expressing empathy. Empathy is just the ability to understand and appreciate what someone else is feeling, right? But we don't feel that emotion ourselves. Okay. And so it allows us to understand how someone is feeling, why they feel that way. It also helps us to maintain control of our own emotions as well as to think clearly, right? So being empathetic with our clients, with our coworkers, using open communication. We know, again, I can't utterly express how important it is to, right? Communication is such a key part of everything that we do. Clarifying information and being aware of our body language. And so remember that our verbal and our nonverbal messages need to match, right?
Mm-hmm.
How we say things needs, if we're trying to present ourselves as being helpful and nice, right? Then we should be smiling and be open. We shouldn't be, oh yeah, I'm just trying to be nice to you, right? We need to make sure that we're matching with our verbal and our nonverbal. It also means too that we need to recognize the cues in our clients, right? Um, if they say I'm not in pain, but they're crying and they're cringing and they're guarding, right? That's an incongruence with our verbal and our nonverbal communication, and we need to be aware of it. Some of the factors that affect communication, personal characteristics, things like age, income, gender, life experiences. These can all be barriers to communication, right? And it's for a variety of different reasons. Can they be a barrier to communication? It could be, an older adult who doesn't hear very well, right? Or, so we have to find some different ways, or better ways to communicate with them. Um, Income, unfortunately, can affect their health literacy. So we need to make sure that we are providing information that is at that fifth grade level, right? To make sure that they can, and it's in basic words, so that they can understand the information. Life experience. Life experiences plays a big part in how somebody communicates. Um, and even what their previous experience is with other members in healthcare. Cultural characteristics, personal space, language, values. Everybody, right, has different views on personal space, 6 feet, 2 feet, 10 feet, whatever. That can be, very well based off of culture. Language can, we have to, are they speaking, or, are we speaking the same language, or do we need to find an interpreter to make sure that they are getting the information that they need in their native language? Situational influences, noise. I think noise is probably one of the biggest barriers that we have in healthcare. And this happens to me almost all the time, where you go in and you're trying to talk to a client and the TV is up on 100.
Mm-hmm.
All you want to do is turn it down a little bit. And they're like, I'm watching that. I'm like, okay, I perfectly understand that you are watching that. I said, but I do need to ask you a couple questions. Can we turn it down just temporarily? What their physical and their emotional state is, right? If I'm in pain, if I'm upset, if something devastating has just happened, right? I'm not going to hear what you have to say, right? We need to calm down, de-escalate a little bit before we can have a conversation. Odors, we know odors can be a big play in things, especially in your, potentially some of your clients that are incontinent. It could be food odors, or wound odors, like all of those. And then distractions, you're in a patient's room or a client's room and you're having a conversation and you have another nurse, another CNA, respiratory therapy, PT, OT, whoever is like interrupting, and you're not able to focus all of your attention on that conversation that you're having, right? So these are some really common situational influences that we can see. And even the background and the circumstances leading to the conversation, right? Am I going in to have a conversation that's a happy conversation, or is this conversation about a potentially life-threatening diagnosis, terminal diagnosis, right? What conversation am I going in to have with my client? Our negative communication blocks, generalized answers. Um, just, trying to avoid those generalized answers. Or, I'll have somebody else come and explain that to you, or, something along those lines. Avoiding false reassurances like, oh, it's going to be okay. You don't know that, right? You don't know it's going to be okay. And so we have to be really, really careful about how we, do that. Um, Conflicting messages is another one. Um, Probing is another thing that we want to avoid as well. This is pushing for more information beyond what we need to know. I know sometimes we get curious about things, right? But if it's not if it's not information that we need, right, then we need to, respect their privacy. Judging, this is another one, judging their behaviors, their lifestyle, all of that. You're not going to be able to establish that therapeutic relationship if you're judging your patient. You don't have to support their bad choices, okay? And we're going to provide education as to, help them to stay away from those bad choices, right? But everybody has the choice to live their life, right? Belittling, or mimicking or making fun of the client. Um, that's a negative communication block. And we don't give advice. I know it's very tempting, but we don't give advice. If they ask you what you would do, you know, kind of reflect that back on them. Like, what ideas do you have? What are your options? What do you think that you can do? And then avoid the simple answers, right? And so, it just, if they're feeling some sort of a way, don't dismiss them. Don't you don't want them to feel like we've dismissed them or we misunderstood them. Um, their feelings are individual, so we want to try to just be as supportive as possible. And then we had our behavior styles, which was your assertiveness and your aggressive, right? Um, and so non-assertive or passive is fear-based behavior. It's emotionally dishonest, it's self-defeating. These nurses tend to look the other way, they avoid conflict, they take the easy way out. Um, and then your um you're aggressive, right? It's I'm trying to think of the best way. Is not assertive, it's more uh violating the rights of others, right? It's more of attack on a person. And then your assertiveness or your assertive behavior is another name for honesty. It's a way to live the truth from your innermost being and to express the truth in thought, in word, and in deed. And it's not just what you say, but how you say it, right? So this is going to be your body language, and how you project your voice. So I don't know why the answers are right there, but the style that would be used to advocate for your patient would be the assertive style. The passive would pass the buck. And the confrontational would be your aggressive. When we look at your risk for workplace violence, um, some of the risks for workplace violence is the location of the facility. Where is the facility? Is it in a high crime area? Um, would be one of the risks. I'm trying to think of some of the others. Um, if they don't have a secure area or even security personnel that are present, and then the condition of the client would increase the risk for um, workplace violence. So are they under the influence of drugs or alcohol? Do they have a mental illness? Are they combative? Or do they have an injury, a head injury? Head injuries, depending on the head injury, but some of them can be pretty severe, right? And cause some changes in their personality. With sexual harassment, if you are the target of sexual harassment is just about abuse of power. It's not about sex, it's not about passion. All right, it is all about power and control. So if you are the target of sexual harassment, the first thing that you want to do is confront that person. All right, be assertive and let them know that the behavior is offensive to you and that it is unwanted. You want to make sure that you're firm when you say that and that your body language and what you're saying are congruent, right? So your message must be congruent so that the verbalization, body language, and effective communication all say the same thing. So first thing you're going to do is confront them. And then we go into our chapters 10 and 11, which is going to be our cultural and our spiritual needs. So cultural skills, cultural competence. So cultural competence is the continuous attempt to gain the knowledge and skills that allow you to effectively provide care for clients of different cultures. Cultural sensitivity is an awareness of different cultures, and continually learning about people who are different from you. Cultural diversity is the differences in the elements of culture in groups of people. And then your enculturation is the process of learning your culture, the way your group does things. And so, it's looking at your culture and what is important and what do they do, right? How does your culture do things? So when we look at cultural diversity and things that we need to consider, their clients' needs, their preferences, their values. How can we make sure that we are incorporating their cultural needs, their cultural values and preferences into the plan of care that we need to provide? Communication, we may provide, we may speak different languages. And also, again, some of those nonverbal behaviors may be different than what we would expect, right? And so making sure that we have interpreters available, right? So that we can communicate with them appropriately and then be respectful of those nonverbal behaviors. Whether it's personal space, whether it's the use of touch, whether it's eye contact, we need to be respectful of that. Of course, food preferences, what they eat, when, how they eat. Our negative effects on culture, your stereotyping. Stereotyping is the assumption used to describe all members of a specific group. Your ethnocentrism is um, that their belief that a cultural group's view or way of doing things is superior. Um, your prejudice is intolerance of another cultural group, and then discrimination is withholding rights or privileges of another cultural group. Our interdisciplinary care team, these are the group of professionals who contribute to care and treatment of a client. They display mutual empathy and understanding. They work together to meet common objectives and promote positive patient outcomes to restore health. All right. And so members of the IDT would be your RNs, your LPNs, your nurse practitioners, your advanced practice nurses, your social workers, your PTs, your OT, your respiratory therapy, your speech therapists, your dietitians, your physicians, your social workers, your care managers, right? It can anybody that is taking care of that patient. It does not have to be a doctor and just a nurse, right? These are everybody in that hospital that helped take care of that client are going to have a role as part of that care plan. All right, so some things to consider. So for one, it's important for the nurse to accept the client's right to their belief and neither agree or disagree with their choice and respect their right to refuse treatment or medication. Our goal is not to change their mind. So if you have a patient that refuses a treatment, refuses a medication, you can ask why. Why do we not want to take this medication? And they're going to give you a reason. We can provide education as to why they should take their medication, okay? But they still have that right to refuse. All right, so we provide education and we document their refusal of care. If a client asks you to pray with them or perform a baptism, what will you do? Some clients that may belong to a religion that does not believe in certain medical treatments. Never assume what a client's choice will be. Offer them the choice and let them make the decision. We can pray with people. We can baptize their child if that is what we need to do. And when we look at some clients, belonging to a religion that doesn't believe in certain medical treatments, I have a good example. I worked with a Jehovah Witness patient, Jehovah Witness. I worked with a client who was a Jehovah Witness. I'm going to get it out. Who needed a blood transfusion. I forget, his hemoglobin was really, really low. I don't remember exact number. And so the doctor was like, hey, ordered a blood transfusion. And so I had let the doctor know, hey, he's a Jehovah Witness, but I will let him know, like, this is what his options are. And so his family was there, and we were openly discussing it and with his permission. And so, I said, well, the doctor would like you to have a blood transfusion. And his family were like, oh, no, he can't have a blood transfusion. And he looked me dead in the eye and he goes, I want the blood transfusion. And I was like, okay. So even though he was a Jehovah Witness and, even in front of his family, he was like, no, he goes, if I need the blood transfusion, because, then I'm going to have the blood transfusion. So I was like, got you. So just never assume what their choice will be because, they may make a decision. Um, and then clients may have different food preferences or times to eat. So utilize the appropriate healthcare team member. Don't try and do everything, teamwork. This is something too that I have seen too, different food preferences. If the hospital can't provide the food that they need, sometimes family will bring food in that's culturally appropriate. not everybody wants to eat breakfast at 7 o'clock in the morning, right? They may not, like, I'm gonna sleep till 8 or 9. That's when I eat breakfast, right? So we can try to sometimes, accommodate those needs, to those patients. It just depends on the situation. But, we try to be as what's the word I'm looking for? We try to be as flexible as possible with certain things, right? That we can incorporate within the plan of care, that as long as it's not infringing on their rights or the rights of anybody, or if it's not harmful or it's infringing or if it's not infringing on the rights of others, then it's okay. Oh yeah. All right. Any questions? Sorry about the little Zoom mishap.
No, you're fine. No, I'm okay.
All right. All right. Well, I will get this posted in the I don't know what's going on with my computer. I will get this posted in the announcement so everybody has access. If you think of any questions, if you need anything, just feel free to reach out to me, okay?
Yes, ma'am. Thank you.
You're welcome.
Have a good night.